If you're not speaking, that you stay muted so that we can ensure a quality recording. And also before you speak, if you just be sure to state your name, that would be great as well. And with that, I would like to officially welcome everybody to the December meeting of the Long-Term Care Planning Committee. We have a full and really exciting agenda today. I'm very pleased with the updates that you're all going to hear. We're going to kick the meeting off with adopting our minutes and everything, but we're going to have our annual presentation from the DSS Community Options team on their various initiatives, and they are flat out working so busy trying to get everything up and running, and took the time to put together their annual presentation and give up some time for us. So I greatly appreciate Christine and all her staff and their efforts. We're then going to have our first report outs of the work groups that we formed, that we've been talking about since June and got established. Those work groups came together and have met. So I look forward to introducing you to their leaders and hearing the updates. So before we dive into business, I'm going to start off by calling the roll. And if you would just please announce yourself that when I call your name, that would be great. And if, all right. Christine Weston. Here. William Seals. Margie Gerondo Marquette. Here. Krista Ostaszewski. No. Aaron Levitt-Smith.
Here.
Aaron, is this your last meeting or do we have more?
Well, it's my official last meeting. I hope if I come back for the TWR that I would come to the March meeting, but today is my official last one. Yes.
Oh, congratulations, Aaron. We're going to really miss you. I hope the TWR comes through selfishly. Let's see, Barbara Cass.
Good morning, everyone. Present.
Commissioner Amy Porter.
I'm here. Thank you.
Jessica Rival. She might have told me she's not. Let's see, Lisa Rivers.
Here.
Michael Santoro.
Present and accounted for.
Laura Watson.
Here.
Okay. Oh, I thought I saw you. Okay, great.
Sorry. I had too much to open. I had to find the microphone.
Thanks for joining us, Laura. Okay. Representative Garibay, I don't think I see her, and Representative Belinsky.
Here. Thank you very much.
Representative. All right. So with that, let's jump right into our first agenda item, which is I would like to entertain a motion to adopt the minutes from the September 9th meeting. You all should have received the minutes and hopefully had an opportunity to look over them. Do I have a motion to approve the minutes from the September 9th meeting?
So moved.
Okay, thank you, Aaron. Do I have a second?
Second.
Okay, second for Michael Santoro. Any discussion or corrections needed? Seeing no discussion, I'll take a vote. All in favor of adopting the minutes from September 9th, 2025? Say aye.
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 Aye. Any opposed? And any abstentions?
I believe this is Amy Porter. I believe I was not there for that meeting, so I will double
Okay.
check that now, but
I
that's my
think you're
recollection,
correct,
so I'll
Commissioner
abstain.
Porter.
Yep, thanks.
I can tell you actually, and you were not. So very,
Thank you. So I'll
I think you were,
abstain.
okay, you were traveling, I believe. So great. So the minutes are approved with Commissioner abstaining. Thanks, everybody. So with that, in the interest of time, I am going to ask that we move into our next item that requires a vote. I had circulated, if you can believe it, it's our last meeting of the 2025 calendar year. I had circulated a proposed schedule for the 2026 calendar year that would keep us at our same meeting cadence, which is the second Tuesday of March, June, September, and December, meeting from 10 to 12 via Microsoft Teams. And I will show you what that looks like. If I can screen share. Okay. So these are what the dates look like. Keeps us on our exact same schedule that we have been on, I think now for 10 years. So with that, I would entertain a motion to adopt the 2026 meeting schedule as presented.
This is Amy, so moved.
Thank you,
Christine
Commissioner.
seconds.
Second by Christine Weston. Any discussion or comment on the proposed schedule? Okay, seeing none, I'll take a voice vote. All in favor of adopting the 2026 schedule as presented, please say aye.
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 Okay, any opposed? Abstentions. Okay, we have officially adopted the 2026 meeting schedule, and I will send out the calendar invites shortly after this meeting. So you all have it on your calendar. And with that, I would now like to formally introduce Christine Weston, our colleague and long-term care planning committee member representing the Department of Social Services. As you all know, she serves as director of the Community Options Unit over at DSS. No small task, she's just in charge of all things Medicaid, home and community-based services. And she and her team, as I said at the start, put together their annual update presentation for us. And with that, Christine, I'll kick it over to you to introduce your team and start the presentation.
Hi, good morning, everyone. I have one housekeeping question. Does anyone hear my heater in the background? Because I will turn it off if it's distracting. Okay, thank you, because I'm very cold in my house, so I'm glad I don't need to turn it off. So yes, hi, very happy to be here and present the December report out for the Medicaid long-term services and supports rebalancing. You know, a lot of you have known me for some time. This is my second year doing it as the Director of Community Options, and then for you to present as a staff member in the unit as well. So today I brought a number of my staff with us, so you don't have to hear me speak through 30 slides. We're also not going to read 30 slides. We are going to be having a dialogue with all of you, giving you high-level updates, some of our highlights, and leaving the meat of the presentation for you to review. And at any time, if there's something in the document that you have questions on or want to contact us about, I can provide my email address to all of you as well. So we'll click through. So I am Christine Weston, as I said, the Director of Community Options, and Melissa did that nice introduction. I've been the director here for 18 months now. And like I said, I had been in the unit previous and came back after some time. Our unit oversees all of the HCBS programs, so all of the Medicaid waivers, the Community First Choice State Plan Program, the Money Follows the Person Demonstration Program, the Chest Housing Initiative, and we housed the ARPA 9817 funding, which was for us to help support HCBS programs and initiatives through ARPA reinvestment. So this presentation is going to touch on a number of those areas and some of the highlights. And again, there's further refined detail in the presentation that we're not going to go word for word for. So joining me is Michael Pecorelli. He is our MFP program manager, as well as our HCBS integration manager. So what we're doing in Community Options is we're trying to take, so historically we had two sides of the house. We had operations and strategy, and the MFP rebalancing was doing a lot of great things with the funding through CMS, but it wasn't always getting carried over to operations. We've now built an integrated unit, and the team is working across the rebalancing initiatives, the nursing home diversion exercises, the reinvestment funding, and carrying it along across all of the programs and operations for us to have one cohesive unit. So Mike is working on our technology integration, so we start using the same systems. And it's really an exciting time to be in Community Options as we're growing and building resources. We have joined with us Vanessa O'Neill Campbell. She is our data steward for the Money Follows the Person program. She will be reporting out on the statistics in the rebalancing for 2025, and we'll be sharing kind of some of our benchmark data. Paul Chase is my associate director at Community Options, so everything I get to do, he gets to do as well. And I'm sure a lot of you have worked with him. He is a institutional knowledge base for all things HCBS, been in the department for well over a decade and is a tremendous resource to us in his new role as associate director, which everyone just made their year. So Mike and Paul have made it a year. Well, I think in 2 weeks will be 1 year in their roles here. So we'll roll into this. So today's topics are going to focus on Money Follows the Person. We're briefly going to touch on CFC. We're going to highlight the American Rescue Plan Act initiatives because that closed September 30th. And we're going to talk to you about the projects we did there and some of the activities that are being sustained. And then we've brought in an HCBS waiver report out. This is new, but this typically we don't report this out. But as I'm saying, we're integrating Community Options, and it's really important that all the good work that we do, that we demonstrate and support in rebalancing and nursing home diversion is carried over to our other programs. And we're going to start talking about the work we're going to be doing in the other programs and start revitalizing like kind of the waivers, how they've always operated. We're going to try to improve and enhance those experiences as well. So we're going to start with Money Follows the Person, and I'm going to turn this over to Mike Pecorelli to do the kind of elevator pitch on MFP and give you some information. So Mike.
Yep. Hi, everyone. Thanks, Christine. So as everyone said, I'm Michael Pecorelli, the MFP Program Manager and HCBS Integration Manager for Community Options. I've been with DSS for 6.5 years now, but I've worked with MFP since 2016 in all different capacities. So as some of you or most of you are aware, MFP has been one of our foundational programs in rebalancing since 2008. We've worked alongside with CMS and all of our partners to sustain and get funding to support our transitions from the institution settings back to community, and working to keep individuals in the community and get them out of institutions where they have the choice to receive their long-term services and supports. So we're committed to serving our Medicaid members in their setting of choice so that they can thrive where they want to be, whether it's in an institution or in the community. So next slide. So this is just a quick high-level overview of our MFP transitions from year to date. So from January 1st to as of yesterday, we have successfully transitioned 383 individuals to the community. And in the chart, you'll see on the high-level overview of what waivers or programs they have transitioned to, whether it's ABI, CHCPE, the mental health waiver. Again, I'm not going to read every one of these, but 383 transitions so far, and we're still have another 2-3 weeks left of the year. So hoping we have as of now, we have about 20 more plans. So hopefully we'll be crossing into the 400 mark. So that's exciting news. So we're staying right on trend where we have been for the past couple of years. We do know that some of the transitions have been lower compared to previous years. And a lot of that is there's a lot of barriers these days. As everyone knows, housing is a huge barrier for us in MFP across the board. It's really hard and impossible to find housing for some of these individuals, and in some of the areas of the state, like Fairfield County has real challenges compared to Hartford County. But our teams are working diligently and trying the best to find housing in these spaces for the individuals. So still having almost 400 transitions is still an achievement. So those almost 400 members have been able to receive their services and supports in the community versus an institution setting. So while it might not have been as high as other years, we're still grateful that we were able to transition this many individuals with all of our barriers that we currently have. Next slide. So MFP, since 2008, we have established 5 benchmarks. I'm going to just quickly go over these 2, and then Vanessa will talk about the other ones. Some of our benchmarks that we've talked about, these are 2 of them. Our first benchmark was to initially transition 5,200 people to the community from an institution. And as you can see, this number is as of September 30th. So we have transitioned almost 8,700 individuals. And again, that number is as of September. So yay for us. That is a huge number, and we love seeing that number grow. One of the other benchmarks is to increase the dollars to home and community-based services. So as you can see, the home and community-based care benchmark number 2 has been a constant, slowly increasing. There was a dip in one year, but it still continues to go up, where they're receiving more home and community-based care in the community versus an institution. And our other benchmark is the percentage of hospital discharges to home and community versus a skilled nursing facility, which is exciting to see. So more people are being transitioned to the community, back to their home versus a skilled nursing facility after they've been in the hospital. So to continue to see these numbers grow and the benchmarks continuing to rise does show that, MFP is a good program. We're working really hard with everybody to continue and try to increase these benchmarks even more. But overall, they continue to grow. So that's my high level MFP pitch.
I think I'm going to stop sharing for a second. I think hold on. Hold on. I want to make sure that the right graphics were put in. I think that was the wrong graphic.
They are. I checked them. You put the wrong date in the bottom. I checked
they were updated. So the slide was updated by the team. So we'll make sure when this gets distributed that the correct slides are up. Mike, if you want to, I think Vanessa, you're going to need to call up our last benchmark report, because it looks like these are carried over wrong.
Okay.
But they shouldn't have been, because they were updated. So I apologize. It might just be a version control issue. So I'm going to reshare. So I apologize for that. But we're trending upwards. It's only missing a little bit of data, and we'll have that for the next one. Hold on, I'm going to get back in for Vanessa to go over the next set of data. This is current. So go ahead, Vanessa.
Okay, thank you. As Christine mentioned, I'm Vanessa O'Neill Campbell. I'm the data quality analyst for Money Follows the Person. And I'm going to be going on a referral assigned to the field by quarters. And this is an increased probability of returning to the community during the 6 months following the nursing home admission. And as you can see here, we're in the third quarter, we got up to the third quarter of 2025. And for quarter 1, 2, and 3, we have been trending quite well. As you can see, the increase still of 447. And also for the number of transition by quarter, down at the bottom for all 3 quarters as well, there was a little dip in quarter 1. But again, we were able to increase our numbers for quarter 2 and quarter 3, still trending favorably up higher, which is good. The next slide. And also for the percentage for the nursing facility admissions, returning to the community within 6 months. Again, this is an increase of percentage of long-term, there was an increase of the probability of returning to the community. And this is for within 6 months. There was also the same trending for the past 3 years to the 6 months. So 2024 is still about the same with the 34%. Moving over to benchmark 5. This is also an increase of percentage of long-term care participants living in a community compared to an institution. So long-term care community versus institution for the past 3 years also has been trending very favorably, moving up more so for the home and community care, which is also has been good. And with a survey of our clients of how whether they're happy, unhappy, through the first month and also the 12th month. As you can see in the first month, there was very favorable of 86% of happy clients, and as well as within the 12 months, 87% of happy clients. And that is a very good favorable number there for us for MFP. And
Okay,
I will go to the next slide.
Okay, so thank you, Vanessa. I'm going to just ask, I have Michael Pecorelli just quickly display the benchmark. I don't know how the wrong graphics were grabbed. You can QA a document all you want, but Mike's going to share. This is our current benchmark for ending 9/30/2025. Mike, you want to just walk through those same numbers again that Vanessa just covered?
Yeah. So just Vanessa was going through like I said, I reviewed benchmark 1 where we said the 5,200. So as you can see, I think the numbers were accurate. It was just the dates on the bottom. They didn't add the.
Well, these are still 24 as well. All right. So we definitely, I apologize. This is, where it's a work in progress. This says 25 as well. We'll follow up with our, with further updated information. This is what's on the current report. I apologize. Things are going well though. All evidence to the contrary, I suppose. Okay, so we'll roll into Community First Choice. So our Community First Choice manager right now is supporting some interviews for new positions in our unit. So we are going to have Mike briefly walk through the CFC slides and then go into highlighting the ARPA work following this. So this is just a high-level update on Community First Choice.
Hi, everyone again. So yes, so our manager's doing interviews, so I'll be covering for him. So Michael Pecorelli. So the Community First Choice program, as you know, is a very large program. We currently have, we're currently serving roughly 4,000 members who are on just our CFC standalone program that have no waiver attached to it. And then we have about 3,200 individuals who receive CFC services who are on a waiver. And on the right side, you'll see the you'll see the waivers and what program they're broken down into, and how they receive those Community First Choice services under that specific waiver. So total 7,200 individuals receiving Community First Choice is a very, very large number. And so we're diligently continuing to work on this program. Next slide. So our current, we're going to talk about the current FI. GT Independence is our new FI. Well, they've been with us for 1.5 years now. So since March 24th, 2024, GTI took over from Allied. And after multiple working with them, we've discovered some administrative and programmatic issues that we're actively working to mitigate and to fix so that we continuously serve our members as best as we can. There was an increase in grievances from the PCA union and complaints from the members during the last quarter of 2025. And of course, we are still working directly with GTI to resolve all these issues for all of our members. Also, the collective bargaining agreement, there were 2 wage increases that occurred in 2025, and there's another one slated for January of 2026. So the PCAs under the self-direction are continuously getting raises, which is fantastic. They've also implemented PTO and the accrual rate and carryover increases. So in addition to additional holidays were added, Juneteenth and Labor Day. And of course, we have a new collective bargaining agreement being worked on between the Workforce Council, the labor unions, and the SIA 1199 for 2026 implementation. With any new collective bargaining agreement comes increase of everything for us. So we're continuing to work and hopefully we'll be in a better place. Well, as Christine said, CFC is a massive program and we're a small unit, but we're doing as best as we can to resolve any issues that any of our members have.
Thanks, Mike. So we're going to go into the American Rescue Plan 9817 funding. That's just a fun way of saying the funding that was allocated to home and community-based services. So the department closed out our ARPA funding on September 30th, 2025. We had funding that supported a value-based payment initiative, enhancements to the universal assessment, in-home safety grants, incorporating COPE and Capable, which are evidence-based models, into the waivers, and we worked on a feasibility study. So of those, all of those topics, we're going to hit some details on the 3 bolded areas, and the rest can be found. We have our link to the site and details of each of the programs embedded in the deck. But to speak a little bit about value-based payments, we had done a number of payments to get people prepared to work within the Connie portal. And so Connie is the state's HIE, the Health Information Exchange. And what we did with the funding was we built an additional portal for HCBS waiver providers as well as home health agencies to come into the portal and start seeing key factors around the individuals they serve to help better support them in their home and community-based settings. That would then initiate value-based payments to support quality and our performance measures of decreasing avoidable hospitalizations, meeting person-centered goals, and discharge from hospital setting in the community, which is currently pending. We're not quite ready to, we're still doing analysis on that, but those are our performance measures. So it took a lot of work. This was, I don't know if anyone's ever tried to dig into value-based payments before, but it is an extremely complicated space. We had a lot of struggles with trying to find the right mixture of how to measure the people. What is an appropriate panel size, meaning how many members are they serving for it to be reliable? How do you serve, how do you still provide value-based payments for agencies that have very small sets of Medicaid members? And it was a very complicated few years to stand this up. We did start doing payments. Our outcome-based payments started in May, and 140 organizations out of 227 that had kind of gone through the onboarding process were eligible for payment. And then we are issuing, I think the other payment just posted to people's accounts this week for the December 2025 payment, and that was 163 organizations out of 233 that were eligible for payments, received payments. So we have tried to be fairly transparent in how we are assessing these agencies. We're putting up the methodology on our website. We're meeting individually one-on-one with agencies for them to understand their data, understand how to use the portal. It is a work in progress. This will take time for people to kind of get used to going into Connie, looking at the information about the members they serve and how best to translate that into day-to-day practice. So we are happy to have issued some outcome-based payments, and we're going to continue to ramp up over time. But there certainly was a learning curve doing this. And it's a very complicated set of measures and activity that took a lot of planning, but very happy that we've gotten 2 payments out on outcome-based. The other payments were all for kind of ramp up and onboarding and orientation and training. So this was a nice shift that this year we were able to actually issue outcome-based payments based on their performance. Our in-home safety enhancement project, we provided an opportunity for home health agencies and the 4 access agencies to reach out and request funding that aligned with interventions to support in-home staff and their safety. So we were expecting funding requests for emergency response buttons like push buttons, funding buddies or escorts on high-risk visits, GPS tracking, and hiring safety consultants or having dedicated phone lines. We really allowed the agencies to come to us with what they were looking to do for their staff. So since November 2024, $4 million was distributed amongst the access agencies and 36 home health agencies to enhance the safety of critical workforce essential to providing home and community-based services. We're currently in the reconciliation process, and we're going to be sending out a survey by UConn was sent to the grant fund recipients to evaluate the effectiveness of the initiatives that they were able to stand up with the $4 million. We've had anecdotal feedback that, the agencies were very happy. We did have a very low response rate, so we did try to engage with the associations. We made this application as easy as possible, but, as you can see, only 36 home health agencies out of, I believe we have, 69 or 70, Barbara, I think there's a handful. There's a whole host of people that did not ask for funding, which was just, we were very surprised by that, quite honestly. And we kept saying, there's money available. Do you want to come now? Do you want money now? And they did not want the funding. We made it an easy attestation. We gave them all of a simple path. It wasn't like they had to contract with the state, but we still were able to distribute $4 million, which is a substantial amount of money directly into in-home support staff. So we're very pleased with that. But we'll be interested when we get the survey results back, what lessons we learned from this. But we really did try to make it as painless as possible, and are very happy that for the agencies that did take advantage of it, that they were able to enhance that level of support to their staff. Okay, PACE. So those of you there's some of you on this call that may have been part of the work group, the Program for All-Inclusive Care for the Elderly. We did a feasibility study. We did a market analysis and a readiness assessment for Connecticut. It included an overview of PACE, eligibility, the objectives, the landscape, and then challenges of enrollment. We haven't done the second phase yet, but we did the market analysis. And I'm going to give you the highlights of that. So this is dense, but so you can read through it. But our key findings, some of it was trying to find the right mix of, it was very interesting trying to explain the 169 unique towns of Connecticut to the consultants that weren't from Connecticut that were working with us, and understanding how, just because they look like they're a few towns away, 95, you're not going from, Stamford to Milford. Even though it looks like you could go from Stamford to Milford, you can't. And if you're in Franklin and trying to get to New London, and the concept of our interstates and how our towns work and how our communities are clustered. They also found, the substantial kind of income disparities on border towns and what that impact would do on where you place the PACE facility, and the socioeconomic challenges of people being eligible for services versus the population count in those towns. They did identify that it's going to cost a significant amount of money to start up these programs. The initial investment in capital, personnel, and systems may not be recovered for many years, and it could be challenging for a new provider or someone coming into Connecticut to stand up in our communities that may not have the population density to be as dynamic as possible for PACE. Other feedback is the workforce shortage. To have a PACE program and to have all of these individuals that need to now have staff deployed to their homes or bring them into the center could be complicated in a highly concentrated area, and that we would have to address workforce in any of our plans. They also talked about housing and shared that PACE organizations could bring innovative solutions to housing challenges. So we were very interested in understanding what that meant. And if we do stand up any kind of PACE program, would there be an opportunity for housing support? So that is an interesting path to take down if we move forward with PACE in Connecticut. And then they found that they heard from stakeholders that behavioral health in older adults was a concern, and that any PACE program designed in Connecticut should certainly have a behavioral health component. That's not necessarily, here or there, but it just wanted to make sure that Connecticut wanted to make sure that if any PACE program was stood up, it had a strong behavioral health component. So some exciting news was that in October, Connecticut applied for federal funding under the Rural Health Transformation Grant, and a PACE pilot program was included in that proposal. For those of you that were on the workforce, this is probably, I hope you heard about this, or if this is the first time you're hearing about this, this is great news. So if the state does get this funding, we would be exploring a hub for duly eligible Medicare and Medicaid and surrounding rural communities in the Northwest Hills planning region. So because this was rural health transformation, we had to identify an area that had the rural health needs, as well as some proximity to other areas that could help build up the population count, because PACE only works kind of in a population dense area. But if you're close to rural communities, you can make it. So we have the Northwest Hills, if you can envision that part of the state, Torrington, Litchfield, Waterbury, that universe. The regional hub will integrate primary behavioral and long-term care, reduce avoidable hospitalization, support aging in place, and promote independence. So I don't know the time frame for hearing about rural health, but I think it was pretty fast turnaround. So we'll know if this is something that's rolling probably in the next few months. So this was exciting news for that work group because I know there was a large interest for exploring PACE possibilities in Connecticut. Okay, so now you get to stop hearing from me, and we're going to be very quickly on a waiver report out, and then we'll be done, Melissa. So this is going to turn over to Paul Chase, Associate Director of Community Options.
Morning, everybody. See lots of familiar faces and names here, so it's good to see everybody in one place. Christine mentioned before, I've been with Community Options now for 12 years. I've been with the department for 20, working in LTSS for pretty much the whole time. But I've been working with our waiver programs the last 12 years as a member of Community Options. Going to give you a brief update and report out on where we are with our waivers, pretty much just where we sit with our numbers and a few noteworthy things about a few of the waiver programs. CHCPE, Connecticut Home Care Program for Elders, our largest waiver. Currently, you see there's over 16,000 active participants. Another 2,000 plus are somewhere in the enrollment process pending either clinically or financially. Statutorily, there is no wait list for CHCP, which is a good thing. I didn't have it on the slide, but our state-funded program is also serving another 1,900 consumers right now, with another approximately 2,000 somewhere in the pending, somewhere in the pending process. So we're serving a lot of people on CHCP. In my 12 years, it's exponentially larger, much larger, the highest number we've ever served on the program. And our staff is doing a really good job, serving that many participants. Something noteworthy with CHCP, for some of you may be familiar with our adult family living, our AFL service. It's a service that's available within CHCP and also in the personal care attendant waiver. It's a service model that provides, allows for a caregiver to live with the member who's receiving the services. It's an agency-based service, so there's an agency that has oversight over the services. They provide a tax-free stipend under the difficulty care exemption with the IRS to the caregiver. And we've seen enrollment and usage of this service explode in the last 2 years. And one of our initiatives in 2026 is to really revamp the service, as you see here, strengthen the service definition, enhance the quality. It's a service that's very desirable and people are using it, more in the last 2 years. I mean, I think it's doubled in usage in the last 2 years. So, that's something we're really going to be working hard on in 2026. So for the personal care attendant waiver, our PCA waiver, Right now, there's just over 1,000 active participants. We have 59 people that are currently pending enrollment. There is a relatively substantial wait list of over 1,300 people. Whenever we have waitlisted waivers that do have wait lists, we hate to put a time associated with that number because you never know. We film by attrition, but we also have certain constraints beyond just if 200 people can't come off, we can't necessarily just put 200 people back on. We have number constraints within each waiver with CMS. So we fill the spots as soon as we can when individuals come off, and we take people off the wait list. Next slide. So we have our two ABI waivers. ABI 1 still has just over 200 active participants. Intake was frozen years ago, so that's why you'll see there's nobody pending or waiting for that. That was in, I believe, 2015 or 2017. That was frozen when we created the ABI 2 waiver. That is our active and open for enrollment ABI waiver. There's 280 participants right now, active participants, only one pending enrollment, and there's 70 on the wait list. And that is an example of, with the only one pending enrollment, that's where we ran up against the maximum amount of numbers we could serve in a year. So we're unable to take any additional people off the wait list in this waiver year. So we're waiting for that to roll over so we can offer more spots in the next waiver year. Next waiver is the autism waiver. 255 active participants. We have 46 that are somewhere in the pending enrollment process. And as you see, a large number of individuals on the wait list, over 2,500 individuals. You heard Christine mention before that some of our management staff are unavailable. They're conducting interviews. That's that next bullet point. They're conducting some interviews for case management staff for the autism waiver in order to be able to serve more individuals. There's funding that supports 640 spots by the end of next year. It's going to be hard for us to reach that goal just based on the fact that we have to staff up these case managers in order to be able to serve, the amount of individuals that we want to be able to serve. But we're trying our hardest. We're definitely focusing on it to try to get as many people on as we can in the upcoming year. Next slide. Mental health waiver is administered by our sister agency in Demas. I saw Katie Daly on here earlier. You gave me these numbers yesterday. Thank you. You have 562 active participants. I grouped together all the pending enrollments. Somewhere there's 47 people that are somewhere in the enrollment process, and Demas luckily does not currently have a wait list for the mental health waiver. Then we have the Katie Beckett waiver, serves our medically fragile children. Recent legislation in 2025 lowered the maximum age limit from 21 to 18. That was with the support and encouragement of DSS. Reason being is that disabled individuals that are 18 plus can already access Medicaid on their own without the help, the special income and asset considerations of a waiver. So we are lowering the age limit. We started the process of transitioning those that are 19 and over off the waiver onto our Husky C coverage group, which thereby opens up some more spots on the wait list because that's another one that has a substantial wait list. We have 321 active participants, 16 that are pending enrollment, and 335 on the wait list. We have our 3 DDS waivers. I didn't get an update in time on the numbers with those, but I will get those and we will add that to the deck before we send it out to everybody. We have the comprehensive waiver, employments and day supports waiver, and the individual and family support waiver that is administered by DDS. And that's the last 3 of our waiver programs.
All right, that was a lot. So Melissa, that is in a nutshell, the highlights of community options and our efforts for rebalancing and long-term services and supports at the department. So happy to take questions. If anyone wants to digest and email us questions, you can do that as well. That's it. That's us.
Thank you so much, Christine and team. That was a jam-packed presentation, but with really lots of good information. I see that Erin Levitt-Smith has her hand up. Erin?
Yeah, I just want to thank Christine and Paul for being good partners with us at Demas with the mental health waiver. And it's been a real pleasure working with both of you as we work together. And so I just wanted to publicly thank you for all the work and your availability to us with questions and support.
Thank you, Erin.
Yeah, and as I said to her on our one-on-one the other day, Erin has been a phenomenal steward in the mental health space. She pushes back when she has to. She advocates when she has to. She'll just tell us how ridiculous we are when she has to, but she has been tremendous in her role there at DEMIS, and they are certainly huge shoes to fill, Erin. So thank you. Right back at you. Very happy to have been working with you all these years.
Thank you.
Anybody else? Margie?
Yes, thank you so much for the presentation. And we have some questions about the adult family living services connected to our caregiver program. So just wondering who the contact person would be for that. Is that you, Paul? Or
Yeah,
one
you
of your
can send me
staff?
any questions on
Okay.
AFL. Yes.
Great. Thank you so much.
Okay, any other questions for DSS? As Christine said, she'll be sharing the finalized presentation and I will circulate it to the group and it'll also be posted online after the meeting. Okay, so with that, thanks again. Oh, sorry, one more question from Michael Werner.
Hi, hello. Thank you so much for that presentation. And I just had to ask, since you were mentioning the AFL, are any of your considerations looking at spousal compensation to be able to participate in the program for all of the empty nesters and other folks who might like to take advantage of AFL?
Hi, Michael. I would not have expected that not to be your question. So, and you will be invited to the focus groups that we will be holding. So it is not the department's position to extend Medicaid reimbursement to spouses. So I do, though, however, want to welcome people to be on record and to discuss the importance of it, because I know there is individuals that are advocating for that. So the AFL experience right now where we're at is we did a proximity state analysis of other AFL programs. We're looking at where our gaps are and our inefficiencies are, and we're trying to build at least our base skeleton. And then we're going to go out to the members actively receiving services, the case managers and the advocates and providers, and have listening sessions and opening dialogues around the service. Because it's one of the few programs where providers actually are coming to us saying, can you please make this a little bit tighter? Can you do a little bit more and in oversight and support? So we absolutely are hearing that. So you and your group will be invited to a discussion, Michael. We can arrange how that looks. We're bringing in providers, and then we are going to want to survey the case managers and members as well. So we are really trying to do our due diligence. We just wanted to have something for people to react to, and that's still being internally worked out. So nothing's off the table, but I think it's going to take a lot for us to take that step, but I'm certainly open to hearing it, of course.
Thank you so much. I appreciate that. Thank you.
Okay, Representative Belinsky, I see your hand up. Oh, it won't come off mute? Still muted, Representative. I can't unmute you, unfortunately. Oh, I'm sorry. If you put your question in the chat.
There we go.
Oh,
Can
there
you
you
hear me
go.
now? All right,
Yes,
sorry
sure
about
can.
that. The focus group activity sounds wonderful. I would like to, if it's not too cumbersome, to have Rep. Garibay and I, have the opportunity to sit in on at least some of the focus group activity. It'd be great to hear from from somebody that's not internal about the perceptions of what we're doing and what their needs are and how that all aligns.
Absolutely. Yeah. As Paul mentioned, this service has seen rapid growth. And if anyone with a TV or a radio knows why. So there's some pros and cons to this, right? So one, from a Medicaid perspective, it keeps people people with their loved ones in their setting of choice in their communities, and we're providing tax-free stipends for people who are supposed to be providing the utmost care and respect and dignity and care, right? However, there are some gaps, and it's lending to some potential predatory behaviors that we really need to, as stewards of the tax dollars and the services and the quality standards of the waiver, need to make sure we have on balance quality providers that are ensuring the quality of the caregivers. So that work needs to be done. It is rapid growth. It's a cost-effective service, but it's also but what are we paying for, right? So I don't want to have a cost-effective service if it's not a quality service and it's not enhancing the lives of our individuals, and that there's not a guarantee of kind of health and safety in the homes. So we will be really digging in and designing that program with oversight and, like we said, hearing from the advocate community and the existing providers. So as those invitations roll, we had some goals of doing it for the fall. It looks like it's going to be early spring that those sessions start. But we will make sure that everyone gets those invitations. We want to hear from everyone, because if we're going to do it, we're going to do it once and we're going to do it right, hopefully. And then we can reevaluate after we put in the new standards.
Thank you so much. It's that's a very, very exciting opportunity. Very, 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 very very much looking forward to that. Thanks.
Happy to have you a part of it.
Thank you. And are there any other member questions? No. Okay. So I do just want to direct Planning Committee members and Representative Linsky, you might want to just look. We had a comment in the chat about the parity with the elder waiver not having a wait list, and then other individuals who have similar care needs being served by waiver programs that do have a wait list, and the only difference perhaps being just age. And this is something we've heard quite a bit in recent years about our waiver programs, and that's something that would, to address would require a statutory change and a large budgetary investment. So, but I did want to raise that since, it's a good point that we hear often. So with that, if there's no other questions, we once again thank DSS for their time, and we will circulate that presentation. And now we will move into what is going to become a standing agenda item for this group is work group updates. And as a refresher for members of the work groups who perhaps are not on, or members of the Long-Term Care Planning Committee who may not be on the work groups, and just to have on the record, as you may remember, this group starting in June, we sent our last long-term care plan to the legislature on January 1st of 2025, so just about a year ago. That plan sets forward the goals and recommendations for the state's long-term services and support system through December 31st of 2027. As we were developing that plan and getting ready to send it to the legislature, the groups began to engage in discussion about, does our plan need a refresh? We've been using the same goals for over a decade. The recommendations, there are so many that it's hard to track and really make meaningful progress. And the question came, should we become more revisit our goals, revisit our recommendations, set fewer, more targeted recommendations to move the state forward? And then we began the hard work in June of deciding, yeah, we should. We recommitted. We formed two subcommittee or work groups to help move that work forward, we developed a long-term care long-term care plan development work group that would focus on really helping to get wide-ranging feedback from users of the system, from advocates, providers, the Long-Term Care Advisory Council, our committee members, to inform the over the next 2 years, the development of revised goals and recommendations for our long-term care plan. We also then created a sister work group called the Long-Term Services and Supports Plan Implementation and Progress Tracking Work Group, with the purpose of that work group being to track the state's progress towards implementing the recommendations in the current long-term care plan that runs through end of December 2027, and to find the areas where the state should really be making them a priority and that need to be incorporated into the next long-term care plan. So to be able to make recommendations back to that plan development work group and say, hey, here are some key recommendations where the state has maybe only made minor progress or not a lot of progress, and work still needs to be done. And we recommend you keep these recommendations in the next plan effective January 1st, 2028. Those work groups are critical and show a true recommitment of the members of this long-term care planning committee to get wide-ranging input on the plan and to make sure that the plan actually reflects the values of our state agencies and our state as a whole, and also recommits us to getting wide-ranging input from the individuals who use and rely on our long-term services and support system and work daily in that system to make sure that we have a plan that's actionable and responsive to the true needs of the state. And so with that, after our September meeting, where we as a group revised our guiding principles for what the state's long-term services systems and supports must include. That is a mouthful. And I think we should just go back to saying long-term care for the just so that I don't stumble over my words. But really to look at the system and say, these are our values. We reset our mission as a group and the mission for the long-term care plan. And then we set forth to establish the 2 work groups. And I'm very pleased to announce that both work groups, thanks in large part to all of you members of the Long-Term Care Planning Committee who either stepped up to serve yourself on the committee or nominated a staff member to serve on the work groups. And Michael Werner from the Long-Term Care Advisory Council, who was instrumental in finding advisory council members and members of the community and individuals with lived experience to join our work groups. We were able to get them up and running, and our both groups elected leadership to facilitate the meetings and guide the work. And with that, I am pleased to introduce our work groups to provide updates on their composition and the work they have done so far. We'll start with our long-term services and supports plan development work group. And that is our co-leaders for this group are Deb Mignol and Heidi Gill. And Heidi, I believe, is going to be giving the report out of the work that this group has accomplished since our meeting in September. Heidi, are you with us?
I am, Melissa. Thank you so much. I'm Heidi Gill. I'm the Chief Strategy Officer at Live Well, and it's an honor to be part of this really important effort. Christine and team, it was real exciting to see your slides. Since 2011, been a part of just the nursing home diversification side of trying to really shake up the system there, starting at Hartford Healthcare with the Center for Healthy Aging and Leeway in New Haven, and now at LiveWell with diversification for those living with cognitive change. So it's really an honor to do this important and often challenging work. And so with that, we're really trying to put together a process that really holds up this really passionate group of about 14 individuals, Melissa, I think it is, that have come together. Deborah McNeil, who I'm just so honored to work with as a chair because we've worked together in the past to really identify a strong process. And so obviously we want to look at our goals of engaging other stakeholders and the lived experience in ways that are both qualitative in nature and quantitative, and sort of back to those focus groups, being that I think Marky brought up that she's going to be doing some focus groups on aging services. Christine, it sounds like you're going to be doing some focus groups, and we need to do some focus groups. So how do we blend those efforts in a way that are highly productive so we maximize our scope and impact with hearing the voices? So that was a really exciting moment for us, I think, to be like, okay, let's make certain that happens. We talked about making certain our survey has a very intentional approach with the questions asked, how it's disseminated, and also how we really research the best practices that can really bring us a step forward in ways that are leveraging the current work that's in place, but also really expanding innovation across the state. So exciting to get that research underway. I think that the idea and the theme was let's get some fresh ideas, fresh perspectives, and insert and be really mindful. And I think this was Claire who is joining us as a consumer of, and her experiences that said, there's so much out there already that people don't even know. And so as we go out there and we're building our questions, also building awareness simultaneously was something that the group spoke about. So I honor that thought, as well as many other insights. In our first meeting for about 45 minutes, we just talked about what do we need to think about from the standpoint of what's already been done, and philosophically, what's the process that's going to be important for us moving forward as a team to create a shared vision. So the process and what's next, because certainly there's a lot of details I could speak about, but again, I think the next meeting will have a lot more meat to share with you about those details. As Melissa said, really trying to make the recommendations a bit more concise is a really important aspect of this effort, as well as that challenge and natural tension between the broad umbrella expectations that we have, and then sometimes that narrow focus that we have to achieve certain goals. So that tension we need to be very aware of and we'll attend to. But we decided potentially to try on this process that's similar to what you might be familiar with, which is called the SWOT analysis that you do for strategic planning, strengths, weaknesses, opportunities, and threats, and really shake that process up to use a process which is from positive psychology that really does bring in aspects of really thinking about aspirations and opportunities in new ways, and really stretches our thinking to that shared vision place. So we'll be looking at what's the process called SOAR, and it stands for strengths, opportunities, aspirations, and results. Strengths being obviously leveraging our current assets and capabilities that already exist. So many, Christine and team, thank you so much for sharing those slides. It was an example of celebrating some great work that's happening. Opportunities, what are the salient gaps, and where do we need to think about expanding market needs, refining what we already have, and then creating and designing new work. And what are all those opportunities? And then the aspiration helps us look at that shared vision so we can tighten up our philosophies together, tighten up what it is we must be doing, and make certain that we're thinking about things that are non-negotiable as well. Because that's where results come in, where we're maximizing our impact, looking at resources, partnerships, measures, outcomes, all the things that must get done. So the result side is how we round out that process. So we were thinking to try that process on and hopefully report to you the next time we see you all with those findings. Again, what a great group that has joined together. Melissa and Cody are doing a great job supporting us. And I don't know if Deborah wants to say anything. I know she's on the call as well. We look forward to your support and ideas as well.
I don't have anything to add. Just wanted to thank everybody. The last meeting we had a very robust discussion. It was great, and just grateful to have Heidi um, as is helping me to chair. I don't know what the word is. We're calling this work group, but just grateful for the opportunity and look forward to the work. Thank you all.
Thanks so much, Heidi and Deb, for stepping up to co-lead the group. Really appreciate it. Heidi, that was an excellent report out. Appreciate you taking the time to join us today and do that. And SOAR was a new tool to me, so I was excited to learn about that and that process and look forward to diving into it and feeling very energized by the work that we have ahead in both work groups. Actually, when the week ended, with the work groups having had their first meetings, both the work groups have both met twice, and I just left feeling like, okay, we're actually going to be able to get some real meaningful work done on both sides and make an impact. So exciting stuff. Thanks, Heidi. Any questions for Heidi and Deb before we get the report out from the next work group? Okay, our next work group, I want to thank so much Karen DeNorfio, who stepped forward to lead the group. She's still hanging out her sign looking for a co-leader. So feel free, anybody who wants to join the work group and co-lead. But the long-term services and supports plan implementation and progress tracking work group also met. And with that, I will turn it over to Karen to give the update on the good work being done by that group. Karen.
Thank you. Karen DeNorfio, I'm the Director of Operations at Harvest Healthcare. We do behavioral health services across the long-term care continuum. Just my other perspective and my other hat from my past is nursing home administrator, so sort of the provider life from a large nursing home chain. And I echo what Heidi said and what Melissa said about kind of these an exciting place for me. Very excited to be here to hear about the work that's been being done all along and the collaboration and integration moving forward with future and innovative plans. It's very, very exciting. So happy to be here. Definitely would love a co-leader if anyone is interested. But regardless of that, you know, I'm ready to move forward with this group. So it's been great. A couple things to share from our meetings. Members have been solidified for the long-term services and supports progress tracking work group. We've met twice, once on November 20th for a kickoff meeting, and then also on December 5th to officially begin our work, which is a little bit more technical than what Heidi is doing with our progress tracking, but just as exciting. The group is still recruiting for a provider or an advocate and 2 individuals with lived experience, which could be users of the long-term care supports or their family members. And ideas were presented on the last meeting on finding potential members, but if anyone has a name to put forward, please do so. We'd be excited to have them join us and be part of this work. The goals and the work for this group has been presented by Melissa. Thank you so much to get us started, including a complete review of the current long-term care plan short and long-term goals. For some of us, it was our first time really diving into that. So to go over that in depth and with some of her background knowledge on where they came from and what the meaning is was very, very helpful. The group reviewed the previous progress tracking tools and discussed the potential practices on moving forward with how to track the goals. It was decided that the previous goal tracker tool for every goal would be implemented annually as it had been before, ensuring a status update from all entities statewide. Additionally, the group acknowledged the need for closer in-depth monitoring of 3 to 5 critical goals, which can be reevaluated on a more regular basis to be determined. And as a follow-up to the meeting, the members of the work group will be reviewing the goals and notating areas felt to be more critical, as well as any knowledge or input they have on data already being collected, so as to not reinvent the wheel. And the next meeting will be held on January 9th, where the work group members will collaborate and determine the most critical focus areas and how to implement a tracking system for such goals. Any comments or questions for our group? Thank you so much.
Well, thank you, Karen. Excellent report out. The group is really setting the stage to do a lot of good work to find those areas that state agencies, provider organizations, what do we need to really focus on? And hopefully that will not only inform development of the next plan, but potentially help to guide us as we work to enhance our existing state programs, create new programs, inform policy development. So real exciting work. And Karen, can't thank you enough for your leadership. I would also be remiss if I didn't say that each group also has decided that folks will rotate taking notes. So all our work group members are stepping up to the plate and playing a pivotal role. Cody and I are really appreciative. And I look forward to seeing the group's work move forward. So any other questions on the work groups? Okay, great. Thanks, Karen, Heidi, and Deb. Very much appreciate your time and your leadership. So with that, I'm going to move into member updates and announcements. Do any planning committee members have any updates or announcements that they would like to make at this time? Margie.
Thanks. Just really quick, I just wanted to mention that the Bureau of Aging is hiring a planning analyst. It's a refill of our position, and the position closes on Monday. And this is the person who works on our state plan on aging. And we hope with these new work groups, we might be able to have our staff person do a little coordinating and supporting around the long-term services and support plan and the work group as well. So thanks.
Oh, that's a fabulous thought. Great. Thanks, Margie. Anybody else update or announcement? Okay. Michael, we're up to Long-Term Care Advisory Council comments and anything you'd like to share.
Yes, thank you so much, Melissa. First, want to express appreciation to you, Melissa, for the work you've been doing, for Heidi Gill and Deb McNult and Karen D'Onofrio. I know Sheldon, all of your work on our subcommittee groups. Thank you so much for stepping up and helping to serve on those. Also want to express appreciation to Christy Weston and Paul Chase and the team at DSS. Thank you kindly for all of the work you're doing. And it's also great to have Representative Belinsky here, just really to help align all of this work together between the branches. So thank you kindly. We're going to be having our next meeting of the Long-Term Care Advisory Council this coming Thursday, the 11th at 10 a.m. We're going to have Rep. Garibay make some welcoming remarks. And Melissa's going to be there as well to give an update to that group. So just very happy to be here for the last full planning committee meeting of the year. And just want to thank everyone.
Thanks, Michael. Any questions for Michael? Okay. Moving on, is there any other business that individuals would like to raise to the larger committee? At this time, I'm happy to also open it up for public comment. If there are any members of the public joining us who would like to make a comment at this time. Okay. Seeing no other business, I would entertain a motion to adjourn.
Motion to adjourn.
Okay, motion made by Aaron. Aaron, adjourning permanently, perhaps, from our committee.
It's weird. It's weird.
I know.
I've enjoyed this group, but yeah.
Well, I am going to use this then. I should to just one more time say thank you so much for all your years of state service, your work on this committee. Whenever I've needed anything data-wise, insight, perspective-wise, you've been a tremendous partner, a tremendous resource, and I'm going to miss you greatly, both personally and professionally. And I wish you all the best, hoping that you come back as a TWR, and we get to still work with you for a touch longer. But thank you so much.
Thank you, Melissa.
Anybody like to second? Not the goodbye to Aaron, but second our adjournment.
I will second the motion and the thanks to Aaron. So thank you for everything you've done. And I agree. I hope you come back as a TWR for additional support. Thank you.
Thanks.
Okay, second by Commissioner Porter. And with that, happy holidays, everybody. Happy New Year. And I look forward to seeing everyone